Hello, everybody. Welcome to Grand Rounds on Monday, March 21st. We are delighted to have you with us as always, and always a special time when we have really a lifer from Icahn joining us today. Dr. Marcellino, I think, went to medical school, PhD school, internship, residency, fellowship, and is on faculty in the division of Hematology and Medical Oncology up at Icahn, speaking to us today about leukemia. Dr. Marcellino, take it away.
Great. Thank you so much for the invite today and for the kind introduction. So yeah, I've been at Sinai for quite a long time now, but it's been a really exciting ride. I've finally gotten to the place I want to be, being really a physician scientist, where I do a combination of clinical work and have my own laboratory and doing a combination of both clinical and more basic bench research. So I'm going to tell you a little bit about my trajectory so far and sort of the goals of what I'm trying to achieve by incorporating both clinical care with translational research. So chipping away at leukemia. The objectives of this Grand Rounds is at the end to be able to describe clonal hematopoiesis and the clinical risks associated with it, and to differentiate between CHIP, CCUS, and a myeloid malignancy. So just a little bit about the general approach that I've taken is, over the last decade, it's become clear that when people speak of de novo acute leukemia, that it is not really de novo, and that as people age, they have somatic mutations in their hematopoietic cells that can basically increase the risk for several different inflammatory diseases, but also for leukemia. And so I'm particularly interested, coming from the hematologic malignancy side, in predisposition to leukemia. And so today I'll be talking about how we are understanding how CHIP, clonal hematopoiesis, can lead to leukemia. And so this translational approach involves clinical experience and patient data, as well as preclinical laboratory studies, to be able to both prevent and treat leukemia. So the outline of the talk is first to talk about what clonal hematopoiesis is and how this can lead to leukemia, and to give some essential definitions in this field. The second part is going to be focusing on targeting the p53 pathway in leukemia, which is the main part of the bench research that I'm doing. And the third part is how we can think about potential strategy of preventing leukemia in the future. So particularly for this talk, we'll be focused on myeloid disorders. So AML is the most common leukemia in adults, with an incidence of about 4 in 100,000. The estimates for leukemia in the United States for 2022 are about 20,000 new cases of AML, 11,000 deaths, and the majority of these AML cases are in adult patients. The median age at diagnosis is 68, and the 5-year survival rate for adults with AML is about 25%. The mortality exceeds 90% when the age at diagnosis is greater than 65, which really shows us an unmet need for the older population with this disease. And risk classification for leukemia is done by both cytogenetic and molecular abnormalities. 25% of AML cases are considered secondary AML, where about 15 to 20% of these come from a previous myeloid disease, so either being myelodysplastic syndrome or myeloproliferative neoplasms. 5 to 10% are considered therapy related, where you have predisposition due to certain types of agents, including alkylating agents, platinum agents, or topoisomerase inhibitors, as well as radiation. So thinking about how a patient actually gets to leukemia, we know that there are a small percentage of patients who actually have a germline predisposition in one of several genes, including p53, DDX41, GATA2, RUNX1. Sorry, let me just mute my email for a second. Sign out of there. Sorry about that. Okay. So that we know that you can have a germline predisposition, and this is relatively new area in leukemia. We did know that there were risks for pediatric leukemic patients who have mutations in some of these genes. But recently, it's been more recognized that there are adult patients who present later who have mutations, germline mutations in these genes. And then we know that about 20 to 30% of chronic leukemia cases, including myelodysplastic syndrome and myeloproliferative neoplasms, can transition to acute myeloid leukemia. And then as far as the rest that we consider de novo leukemias, we know that a large proportion of the aging population has clonal hematopoiesis, and about 1% per year of these individuals develop acute myeloid leukemia. What causes clonal hematopoiesis? This is an area of active investigation, but we know that increases with age, that certain chemotherapeutics can increase your risk of having CH. Smoking, diabetes, infection, inflammation, as well as germline predisposition. And there are certain to be many more influential factors that are going to be found over the years. And so when we're talking about this, we think about normal hematopoiesis first. And I just point out here that what we know is that there is a multipotent stem cell that when you're born with a certain population of these that over time doesn't change, but that allows for differentiation in both myeloid and lymphoid progenitors. And so the origin of clonal hematopoiesis is important because it's coming from the stem cell. And this means that a mutation that is found in the stem cell can grow out and can cause problems as you age. So the definition of clonal hematopoiesis is expansion of one lineage of cells, which is termed a clone, disproportionately over others. And the fitness advantage from mutations that allow for the expansion of one hematopoietic clone at a higher rate compared to others can be either due to increased self-renewal of that stem cell state or increased proliferation or reduced cell death. And it's been found that hematopoietic cells can travel to different tissues of the body, which can lead to abnormal activation of molecular pathways in differentiated cells such as macrophages. And this can lead to aberrant immune and inflammatory states. So clonal hematopoiesis. So when clonal hematopoiesis was first discovered, it was really delineated in myeloid cells, so along the myeloid line, and much more is known about that. So we will be specifically focusing in this talk on myeloid clonal hematopoiesis, where it's believed that a somatic mutation occurs in either the multipotent stem cell or myeloid progenitor cell. And you can see here on the left, it was actually just published this year, showing a distinction between lymphoid and myeloid clonal hematopoiesis and the genes that are affected. So specifically up in this corner, you can see a list of the top myeloid genes that are mutated in clonal hematopoiesis of myeloid origin. And then as far as lymphoid origin, this is much less studied, but there are very specific lymphoid genes that are associated with what is now considered L-CHIP. We will be again focusing on myeloid clonal hematopoiesis. So then what drives the evolution of clonal hematopoiesis to AML? So if you think of having a normal pool of hematopoietic stem cells and then gaining mutations in certain genes such as DNMT3A, TET2, IDH1, all which are involved in increased self-renewal, then you can see the development of this aberrant clone, with the green being the pre-leukemic hematopoietic stem cells. Then it's believed that there is a second hit in mutations in genes that are involved in enhanced proliferation and impaired differentiation. And together, these mutations work to form a clone that then allows for the development of a full leukemia. So aging not so gracefully. Clonal hematopoiesis increases with age, particularly after the 5th decade of life. It's present in about 10% of individuals aged 70 years old. Again, it is a gradual clonal expansion of hematopoietic stem cells carrying specific disruptive and recurrent genetic variants in individuals without a clear diagnosis of a hematologic malignancy. The median variant allele frequency is between 2.5 to 10%. And when we're thinking about a variant allele frequency, what we're really trying to measure is this is representative of the number of mutant alleles that are present. Clonal hematopoiesis is equal among males and females. However, males are more likely to progress to a hematologic malignancy. When you have clonal hematopoiesis, you're at increased risk of hematologic malignancies, cardiovascular disease, and mortality from non-hematologic cancers. It leads to an increased all-cause mortality hazard ratio of 1.9. And again, clonal hematopoiesis is not a disease. It is actually a normal component of aging. So we generally try to avoid the use of the word patients and talk about individuals with clonal hematopoiesis. And, over the last decade, clonal hematopoiesis has really been sort of muddied by a lot of different acronyms. So it can become very confusing sometimes to follow in the literature, but just to go through a few, CHIP is defined as clonal hematopoiesis of indeterminate potential. And this is when you have a somatic mutation, but you don't have any clinical evidence of disease. So you do not have a cytopenia. CCUS is clonal cytopenia of undetermined significance, where you have both a cytopenia and a mutation. ARCH is another commonly used term, which is age-related clonal hematopoiesis, where you have a somatic mutation. So it's really similar to CHIP, but a lot of publications use this instead of CHIP. What's important for all of these is that you do not meet WHO diagnostic criteria for hematologic neoplasm. The cytopenia cannot be from a known cause. The cytopenia is usually anemia. The mutation should have relation to a hematologic malignancy. The variant allele frequency for mutation should be at least a 2%. However, this has been ever changing. And they found that if they look at microchip, where you have a variant allele frequency of less than 2%, one study showed that 95% of patients greater than 50 had microchip. So again, this is talking that clonal hematopoiesis is really, part of the aging process. What's very important to understand, though, is if you do see a cytopenia, those patients with cytopenias of undetermined significance at 10 years have 95% probability of progression to a myeloid malignancy. So what are the mutations that are found in myeloid CHIP? So this is sort of a general panel that we normally see when people are analyzing in both research and now clinically CHIP mutations. The most common mutations are found in these epigenetic modifiers, DNMT3A, TET2, and ASXL1, and these account for greater than 90% of the CHIP mutations. Particularly interesting for oncology patients who have received other chemotherapy, and also of great interest to my research, are mutations in the DNA damage response pathway, and this is in TP53 and PPM1D. So when we talk about pre-leukemia, what are we talking about? So CHIP can lead to MDS, AML, CLL, aplastic anemia. However, it's important to note that the majority of CHIP will not lead to leukemia. There's an increased prevalence of leukemia in CHIP patients from a relative risk ratio of some say about 10 to 35, depending on the study you're looking at. It's more associated with secondary leukemias following chemotherapy, with a 10-year risk of about 14 versus 4% without CHIP. Decreased survival is found if you have CHIP prior to a bone marrow transplant. And the more mutations you have and the higher the VAF, the more likely you are to progress to a pre-leukemia. So this was a seminal paper published in 2018, which looked at a prediction of acute myeloid leukemia risk in healthy individuals. It analyzed peripheral blood using deep sequencing from 95 pre-AML individuals, which were obtained on an average 6.3 years before AML diagnosis, and 414 control individuals. CHIP was found in 73.4% of pre-AML cases versus 36.7% of controls. It was found at a median of 7.6 years before diagnosis. About 40% of pre-AML cases above age 50 had a driver mutation with a VAF greater than 10% versus only 4% of control. So then the question is, what can increase the risk of clonal hematopoiesis going to acute myeloid leukemia, and who is at the greatest risk? And it was found that specific types of chemotherapy heighten the risk of potentially developing or causing expansion of the clonal hematopoiesis clone. And these were platinum agents, topoisomerase inhibitors, et cetera, which we'll talk about in the next few slides. So in 2017, this seminal paper came out of Sloan looking at therapy-related clonal hematopoiesis in patients with non-hematologic cancer, so with solid malignancies. And they paired peripheral blood and tumor samples from almost 9,000 patients with solid tumors. Clonal hematopoiesis was found in 25% of cancer patients, with about 5% harboring presumptive leukemic driver mutations. Clonal hematopoiesis was associated with increased age, prior radiation therapy, and tobacco use. Specifically, PPM1D and P53 mutations were associated with prior exposure to chemotherapy. CH led to an increased incidence of subsequent hematologic cancers, and CH with specific mutations in leukemia-associated genes was associated with shortened patient survival. And the hypothesis was that P53 mutations at a low level may make you susceptible to genotoxic stress from these therapies. Following that, in 2020, Kelly Bolton published this paper that went in looking deeper into the solid oncology patients and found that radiation, platinum, and topoisomerase II inhibitors preferentially select for mutations in DNA damage response genes, including P53, PPM1D, and CHEK2. The higher your dose of platinum, the higher risk for clonal hematopoiesis. And they also found that smoking selected for ASXL1 mutations. P53 mutations and spliceosome mutations showed high risk for therapy-related myeloid neoplasms. And about 90% of cases that transformed to therapy-related neoplasm had the acquisition of other mutations, including in FLT3, NRAS, and KRAS genes, all involved in differentiation and proliferation. The number of mutations and allele burden were predictive. And they concluded this paper looking at modeling of risk benefit of adjuvant chemotherapy in breast cancer patients. And so this is not clinically prime time yet, but what they basically were able to show is that receiving an additional dose of some adjuvant therapy, for instance, in this case, it was platinum therapy, could put you at such a high risk for developing a therapy-related myeloid neoplasm in comparison to the benefit it gives you against reoccurrence of breast cancer, that it might make sense in some patients who have baseline CHIP to not get an extra cycle of adjuvant chemotherapy. And this is really where the field is going, is trying to understand who is at risk for developing complications from chemotherapy, and can we use basically CHIP as a biomarker for this. So I'm particularly interested in the development of leukemia and myeloid malignancies, but I'd be remiss not to talk about clonal hematopoiesis and its association with cardiovascular disease. And really the seminal work was done in collaboration with Valentin Fuster here at Sinai. And this paper looked at clonal hematopoiesis and the risk of atherosclerotic cardiovascular disease. And they found that carriers of CHIP had a risk of coronary heart disease that was about 2 times as great as in non-carriers. And this was done using prospective cohorts, so very strong data. Participants with CHIP had a risk of MI that was 4 times as great as in non-carriers. And this was done in retrospective cohorts for early CAD detection. But to put this in comparison to, say, hypertension, it's very similar rates. So, you know, we screen people for hypertension and know that association, but here we may have a biomarker that actually shows us who's at risk. Mutations in DNMT3A, TET2, ASXL1, and JAK2 were each individually associated with coronary heart disease. 94 of these patients had a mutation in one single driver gene, so not multiple mutations. The higher the allele burden, the higher the risk of cardiovascular disease. And CHIP carriers with these mutations also had increased coronary artery calcification as well, which is a marker of coronary atherosclerotic burden. And they also did some very nice preclinical work here showing that hypercholesterolemia-prone mice that were engrafted with bone marrow obtained from TET2 knockout mice. So basically this mimicking of a TET2 CHIP mutation had larger atherosclerotic lesions in the aortic root and aorta. And then they took macrophages from these TET2 knockout mice and showed elevated expression of several chemokine and cytokine agents that contribute to atherosclerosis. So for anyone watching this talk in whatever field you are going into or already in, CHIP has basically touched all of that and will continue because it has now been reported to be associated with nearly every medical disease. So generally for the geriatric population, we know that clonal hematopoiesis increases with aging. We found that chronic infection actually drives the expansion of a clonal hematopoiesis clone and thinks that this is mitigated by interferon signaling. In endocrinology, there's a clear interplay between clonal hematopoiesis and metabolism, with diabetes potentially putting you at a higher risk for developing CHIP. In gastroenterology, a recent paper looked at ulcerative colitis patients and found that there was an increased risk of clonal hematopoiesis. In kidney, there's an association with chronic kidney disease. And just at the last American Society of Hematology meeting in 2022, we can see that obesity-induced inflammation has been linked to the development of clonal hematopoiesis and the expansion of this clone. In pulmonology, there's increased incidence of clonal hematopoiesis in lung transplant recipients. In rheumatology, that there's an association with gout. But with all these individuals having CHIP, how do we parse this out? And from my personal interest, who with CHIP is actually high risk for leukemia or for cardiovascular disease or for potentially any other complications associated with it? Who needs surveillance and how do we intervene? So on the clinical side, this past July, I opened a clonal hematopoiesis clinic here at MSBI and have been following patients who have been referred who are thought to have a clonal hematopoiesis clone. And particularly this has been coming from the solid oncology side of things, because they do sequencing and often can find potential mutations that are hematologic mutations when they do the sequencing. Also referred are patients who have cytopenias of unknown origin. So basically iron deficiency and B12 have been ruled out. And so therefore we look to see if they actually have an underlying clone that could be putting them at risk for development of CCUS and potentially MDS or another myeloid disease. And in this clinic, we've been developing, one of the fellows at Mount Sinai and I have been developing a prospective database to really follow these patients. Because as you can see, except for the cardiovascular prospective cohort, most of these studies have been done doing retrospective cohorts. And so to really understand the trajectory of development of myeloid disease from clonal hematopoiesis, prospective cohorts are very important and will take sort of a long amount of time to get that data, because it does take years for patients to develop this. And then I'm the director of the Hematologic Malignancy Tissue Bank at Mount Sinai. So we are able to collect blood specimens from all these patients to be able to do preclinical studies using these. And we've developed several collaborative studies with medicine colleagues, which I'll talk about in a few minutes. So the Clonal Hematopoiesis Clinic was opened in July. Like I said, a lot of these patients are referred from solid malignancy. Some are also referred from the genetics clinic when they're doing germline screening. So particularly when there's concern that patients have P53 mutation, the question is, could this be Li-Fraumeni syndrome, that it's really germline, or could it actually be clonal hematopoiesis? Bone marrow transplant donors have sequencing done, so they often end up in the clinic. And then carrier screenings for pregnancies. We found that CHIP mutations have been found and followed. And this is really a collaboration between geneticists, solid oncologists, hematologists, and we are also going to start working more closely with cardiology. It involves surveillance, early detection, cardiology risk management, and guidance. We do yearly next generation sequencing and complete blood counts. And like I said before, the area of germline mutations that put you at risk for developing leukemia is a very big developing area. So we're also following these patients who have germline mutations that are associated with leukemia. And as far as translational research areas in avenues in this area, so I talked about the prospective database, and we're very interested in looking at the genes that are mutated in these patients, the number of mutations, and the clonal expansion over time, whether there's germline susceptibility to developing clonal hematopoiesis, their clinical history, and also their treatment history. We will be tissue banking these patients and working with basic science and translational researchers and using these, particularly to understand the interplay between the immune system and clonal hematopoiesis, which is being done with Dr. Bayan. And ongoing collaborative projects, for instance, these are a few, is we're evaluating clonal hematopoiesis in long-term survivors of lymphoma after cytotoxic chemotherapy with Dr. Sundaram. We're looking at CHIP and myeloid-derived suppressor cells in patients with neuroendocrine tumors with the neuroendocrine group, specifically Virginia Corbett and Edward Wolin. And then of particular interest to me is working with the GI group, looking at CHIP and inflammatory bowel disease. I talked about that one paper that was published previously about ulcerative colitis patients, but there really hasn't been a large study looking at Crohn's disease and ulcerative colitis patients. And we see quite a few young patients with ulcerative colitis or Crohn's who come in with very refractory acute myeloid leukemia in their 20s and 30s. So it's particularly interesting to go back to actually be able to see potentially if the higher risk of clonal hematopoiesis and potential therapies are exacerbating this risk. So then to go a little bit into actually targeting pathways involved in clonal hematopoiesis, I'm interested in the P53 pathway in leukemia. So a little bit about aging, clonal hematopoiesis, and the P53 pathway. So DNA replication occurs with aging, and mutagens and inflammations instigate DNA damage and expansion of malignant clones. So clonal hematopoiesis and cancer are a consequence of aging and the environment, as well as probably germline genetics. So we know that P53 is really a master regulator that helps prevent the formation of malignancies. But as DNA damage occurs, generally what P53 does is allows for death of the cell that's having aberrant DNA in it, so preventing the formation of a cancer. But if you have different mutations and different mutagens that actually hit DNA over and over again, you can sometimes get too much P53 activity and you're getting a lot of cell death. And the problem that happens is that if you don't have active P53, then you can have cells that actually escape. And there can be a lot of different ways that P53 can become inactivated. So again, if you're knocking out P53, you're decreasing this repair cycle, you're decreasing cell death, and this can lead to aging as well as cancer. So the hypothesis is that the downregulation of the P53 pathway through multiple mechanisms can drive clonal hematopoiesis and progression of myeloid malignancies. So if we think of this as a trajectory, we think clonal hematopoiesis to chronic myeloid diseases to AML. We think that as this happens, this can occur to decrease P53 activity. And how do you decrease P53 activity? So we talked before that you can get mutations and you can get deletions through chromosomal abnormalities. Or you can have the overactivation of negative regulators. So negative regulators of P53 include MDM2, MDM4, and PPM1D. And all of these can work together to decrease P53 activity. And really in many cancers that we have found that there are overexpression of MDM2, MDM4, and PPM1D. A lot of groups have shown this. And I am particularly interested in PPM1D. So just to sort of hit this home about P53 pathway alterations in myeloid malignancies, you can see that P53 mutations are found really across the board, except really in chronic MPNs. Although recent research has shown that even in chronic MPNs, there are very low VAF P53 mutations. And then P53 deletions can occur from deletion of chromosome 17p. And really AMLs or any myeloid disease that have P53 mutations or deletions are very poor prognosis. And then when we speak about P53 negative regulators, again, these are MDM2, MDM4, and PPM1D, we can see that across many studies that there's an increase of these different negative regulators in myeloid disease. So as a model of the progression of disease, I trained with Ronald Hoffman and John Mascarenhas at Mount Sinai, who are specialists in myeloproliferative neoplasms. And so my training is was in this area and really serves as a great model for thinking about the progression of a chronic disease to an acute myeloid leukemia, and thinking of this as sort of the intermediate step between where you go from clonal hematopoiesis to AML. With that said, clonal hematopoiesis doesn't have to go through a chronic leukemia to get to AML, but we believe that the mechanisms that are driving the expansion of the clone and the transition of the disease are similar. So MPNs are serving as a model for progression of myeloid disease, and MPNs are clonal stem cell disorders. The chronic forms of MPN include polycythemia vera and essential thrombocythemia, and they're prone to progression to myelofibrosis and AML. And at 15 years from diagnosis, there's a certain percentage of PV and DT patients that will progress to MF, which is somewhere between 10 and 20%, and about the same percentage of PV and ET patients that will progress to AML. And these patients that progress to this type of AML have a very dismal prognosis of really less than 6 months. And so how do we think that this progression is occurring? So it's the same as what we think with clonal hematopoiesis. There are acquisition of driver mutations in the hematopoietic stem cell, which lead to the chronic disease. And then acquisition of epigenetic and genetic alterations, which can include the development of other myeloid mutations, plus a pro-inflammatory environment, can then lead to the progression to MF or MPN blast phase, which is the form of AML. And so P53 and MPN progression is a very interesting area because they found that low allele burden P53 mutations are found in about 15% of chronic MPN patients. And these are of unclear significance because not everyone with a P53 low-lying mutation will develop MF or AML. They found that P53 loss of heterozygosity and rapid expansion of a P53 mutant clone is associated with transformation to AML. And in PV and ET, P53 mutations have been associated with significantly decreased overall survival. And when they genomically classified over 2,000 chronic MPN patients, they identified that patients with mutations in P53 were a poor prognostic group with increased likelihood of leukemic transformation and decreased overall survival. And in preclinical studies, P53 deletions and mutations promote chronic inflammation, which leads to the development of neoplasia. So this can sometimes be a confusing slide if you're not dealing with mouse modeling, which most of you aren't on a daily basis, but this really brings home the point of sort of preclinical to clinical of what we think is going on. So we can see with a group that we collaborate, Rajit Rampal, as well as another group in Japan, showed that if you have a JAK2 mutant mouse, and JAK2 mutation is the driver mutation found in a large percentage of MPN patients, and you delete P53, you get progression of this polycythemia vera mouse to AML. And so that is a way for us to see how important P53 is in preventing progression of this disease. And so then that's talking about completely just removing P53's activity. But how else can we potentially, in those patients that are not having a full deletion, how can P53 be altered? And then again, that is where our negative regulators come in, MDM2 and MDM4, as well as PPM1D, which can both lead to, expression can lead to decreased P53 activity. So MDM2 and MDM4 both work to decrease P53 transcription and increase its degradation. And MDM2 inhibits P53 in a wide variety of solid and hematologic malignancies. And particularly in MPNs, our group showed that MDM2 is upregulated in CD34 positive, which are stem cells, and that inhibition of MDM2 targets these hematopoietic stem and progenitor cells. Nutlins are a class of drugs that are inhibitors of MDM2, and they're currently in clinical trials for MPNs, and they're showing very promising results. The first trial evaluating this concept in MPNs was led by John Mascarenhas and Ronald Hoffman, my mentors. And this has now led to the development of over about a half a dozen trials in this area with different nutlins and MPNs with very promising results. And then some of the first work I did showed that gain of 1Q in MPNs is associated with transformation of MPNs. And this appears years prior to transformation and increases levels of MDM4 expression. So both MDM2 and MDM4 are most likely acting in concert to cause progression of disease. Again, nutlins, which you're bound to see in the future in the clinic because they're really in many trials for hematologic malignancies at these points, are inhibitors specifically of MDM2. So now for PPM1D, which is the focus of my lab right now. So PPM1D is also called WIP1. It's a phosphatase, so it is known as wild type P53 induced phosphatase. PPM1D terminates the DNA damage response pathway in apoptosis. It downregulates P53 pathway by dephosphorylating P53 and stabilizes MDM2, promoting proteolysis of P53. So basically, we talked about MDM2 and MDM4 interacting. PPM1D also interacts with MDM2. And it was found that there are many malignancies which have PPM1D mutations, but particularly in hematologic malignancies, you can see these exon 6 mutations. And in this figure below, you can see that you can get frame shift and nonsense mutations in exon 6. And what happens is this leads to the loss of the terminal C degradation domain. So this domain right here, which would basically trigger the protein to be able to go to the proteasome and get degraded. But without it, you're inhibiting degradation of the protein. So really, mutation of this gene leads to PPM1D overexpression. And from the studies that we've done, showing that this causes increased clonal fitness. So overall, because it can become very confusing with all the different arrows, it's important to realize that PPM1D mutations lead to greater amounts of PPM1D, which can be cancer promoting. And, I'm very interested in this in leukemias, but PPM1D in cancer in general, it's really been shown across the board to be mutated in many cases and to have mRNA and protein upregulation. So the thought of being able to target this protein is a very interesting concept that could potentially have far-reaching effect across a milieu of cancers. So specifically, this paper came out from the Goodell group, as well as another group up at Harvard, looking at PPM1D and clonal hematopoiesis and myeloid malignancies. So PPM1D is one of the CHIP genes. The prevalence of PPM1D mutations in unselected population was up to 5%, and in patients exposed to chemotherapy, up to about 20%, and has been found in about 15% of MDS cases. It's specifically associated with therapy-related myeloid disorders, previous exposure to platinum, radiation, topoisomerase inhibitors, and high transcript and protein expression in AML correlated with poor risk, with reduced event-free survival and overall survival. And mutations and overexpression of PPM1D have been associated with chemotherapy resistance. In MPNs, it was found that it was the 8th most common mutated gene in MPNs. It was found across the MPN spectrum, PV, ET, and MF, as well as in leukemias that came from MPNs. And the PPM1D mutation could arise in either a wild type clone or in the MPN clone, which is JAK2 positive. And then our group published or presented an abstract at ASH, basically, again, showing that there are PPM1D mutations in MPN patients. About 6% of MPN that progressed to AML harbored at least one mutation, but it was also found in high-risk PV and ET patients. And again, all were these truncating mutations in exon 6. And then to take it a step further, we also saw that there was PPM1D overexpression actually also in PPM wild type MPNs, which again tells us there doesn't necessarily have to be the mutation to have overexpression. And we found that about 40% of patients had overexpression of PPM1D who didn't even have a mutation, again, making it a good target, being it's found in a large population. So this then forwards into how are we looking at using preclinical laboratory studies to understand this, to both elucidate the role of PPM1D using multiple model systems, as well as how can we develop a therapeutic strategy for potentially targeting this protein. So in the laboratory, I've been specifically focusing on MPNs, but also looking at other types of leukemia, and have developed or in the process of developing PPM1D mutation and overexpression MPN mirroring models, where we take a JAK2 mutant model and we cause overexpression of PPM1D in it. And then using primary specimens from MPN and AML patients. So from the tissue bank, we have over 1,000 different MPN patient samples that we can use to study different drugs and to better understand the mechanism of how PPM1D is working. And also particularly interesting, I think, and it's just great to know that these model systems actually exist, is this concept of iPSC line. So iPSCs are induced pluripotent stem cells. And what you can do is we took, this is in collaboration with Irene Pepapetru, who is an expert in this area, or took mononuclear cells from an MPN patient that had both a JAK2 mutation and a PPM1D mutation. And you reprogram them to basically bring them closer back to the stem cell state, and are able to isolate different clones that came from that patient, and that led to this mixed milieu of cells in the MPN patient. And you can see here that we were able to reprogram and actually get one clone that had the JAK2, and then another that had the JAK2 and PPM1D. And what this allows you to do is to directly compare these two clones and to understand how the addition of a PPM1D mutation causes a change in the clone and potentially progression of disease. So using these, we can do many different assays, including transcriptomics, to look at the different signaling pathways that change with this. We can use these to test different standard therapies and to understand resistance, and to also try out our new PPM1D targeted therapies. And to show here just a little bit of where we've started is you can look, if you look at the mutant PPM1D cells versus the wild type PPM1D cells, this is a Western blot and shows us protein expression. You can see that the PPM1D levels are much higher in the PPM1D mutant cells, which is what we would expect. And then when comparing the ability of these cells to grow up and make hematopoietic colonies, which shows us that it's able to really form a leukemia, the PPM1D mutant formed many more colonies than the non-PPM1D mutant. So then the question became, well, how do we target this? So there is a PPM1D inhibitor that was created by GlaxoSmithKline, and we evaluated this in cell lines and primary samples, and wanted to understand if it worked in these, as well as whether we could combine it potentially with MDM2 inhibitors, those nutlins, for synergy. Also wanted to look at the ability to potentially synergy with immunotherapies, because basically a whole other talk could be about PPM1D and the immune system and how that works, which also makes it a very interesting target. And what we showed is that this inhibitor showed activity preclinically in numerous cancers. What we showed this specifically in MPNs, and here we can see that there's decreased colony formation and increased apoptosis, and that the Western blot here is showing that you get increased levels of P53 when you're actually inhibiting PPM1D. And we showed this in MPNs, and other groups have shown it in other cancers. However, this drug had never moved to the clinic. And this is because phosphatases are very difficult to target with inhibitors. And so in collaboration with Jean Jin's group at Sinai, who is the director of therapeutic discovery, we've developed with him what are called PPM1D PROTACs. And PROTACs is a very new, interesting area, are proteolysis targeting chimeras, and they link a protein of interest, in our case, PPM1D, with an E3 ligase. And this forms this ternary complex, which initiates polyubiquitination of your protein of interest, in this case, PPM1D, and basically drags it to the proteasome to be degraded. So you're really causing chemical knockdown. Instead of inhibiting the protein, you're actually bringing it to be degraded. And this is a catalytic process where you basically can keep bringing more and more of the protein with just one molecule of the drug to be degraded. And therefore, it allows for a PROTAC action at very low doses, and it can be dosed much lower than inhibitors. It also allows the potential degradation of undruggable targets, such as non-enzymatic protein-protein interactions, phosphatases, et cetera. And there are currently 3 PROTACs that are in clinical trial. So this is sort of a very new area, but it is moving into the clinic. And so we've looked at the PPM1D PROTAC in some leukemic cell lines, and we show that indeed, if you look here, with increasing dose of the PROTAC, you get decreasing levels of PPM1D and increasing activity of P53 marked by P21. We have screened over 80 compounds and selected the top compounds based on the degree of degradation and the effect on leukemic cells. So we are picking 113 right now because it causes the most degradation and causes the most apoptosis in these leukemic cell lines. And then we've also shown that there's activity in primary MPN samples. So it decreases colony formation and the size of colonies. So to conclude, I just want to go through a few examples of sort of taking this all together, how we think we could use both the clinical data and the bench data to understand how to prevent leukemia. So traditionally, historically, we always go after acute myeloid leukemia when it's, full out. But we know that this is very hard to do because we're only able to cure 25% of patients. What if we treated at earlier time point to help progression of disease at chronic leukemia, or prevented the expansion of a clone when you're receiving chemotherapy, or preventing high-risk clonal hematopoiesis from progressing? So first, historically, so we know that AML patients are often treated with cytarabine-based regimen. And the Cons group showed preclinically that mutated PPM1D or PPM1D overexpression led to cytarabine resistance. Could inhibition of PPM1D overcome this resistance? So for instance, you can see here in red is a leukemic cell, and the X's are the PPM1D mutant or overexpressing. You give cytarabine and you get rid of a lot of the leukemic cells, but those that are PPM1D or mutant or expressing stay around, and therefore it allows potentially for the development of relapsed or refractory disease. What if we were able to inhibit or degrade PPM1D at the same time? Would we be more likely to get a cure by getting rid of these resistant cells? So that's one way to think of how we can actually target these resistant clones. Or in chronic leukemia, as I said, there has been activity of the nutlins, the MDM2 inhibitors. And this has really led to a total change of thought about treating these diseases. But what if you actually could degrade MDM2 instead of inhibit it? Could you get greater potency or less side effects? And then what if we added in targeting PPM1D? There are preclinical studies that have shown that inhibition of both PPM1D with MDM2 can lead to a synergistic effect. How about those receiving chemotherapy? How do we protect them potentially if they have overexpression of PPM1D or a mutant? So take, for instance, a head and neck cancer patient or colorectal cancer patient who's receiving a platinum therapy. They're cured, great. But in the bone marrow, what has been going on? If there were PPM1D mutant cells to start off with, a platinum agent could lead to an increased number of these cells and the risk of developing therapy-related AML over time. Would it make sense to give, with the platinum agent, a PPM1D inhibitor or PROTAC to help prevent that progression and keep the clone at bay? And finally, clonal hematopoiesis. As you've seen, clonal hematopoiesis is associated with many things and is very prevalent. And there's really more clinical data needed to really understand of whether this should be targeted. And so the first risk steps towards clinical intervention in clonal hematopoiesis are really getting started. And there are clinical trials that are being established for high-risk clonal hematopoiesis patients, both looking at leukemia prevention, cardiovascular prevention. The patient needs to be high risk and the prophylactic therapy has to be low toxicity. There are currently IDH1 and 2 inhibitors in trials for patients with cytopenias and IDH mutations. And remember, this makes sense because patients with cytopenias plus a mutation have a really high risk of developing a myeloid disease. So you want to start with your most high risk population to begin with. There's also a trial of vitamin C for clonal cytopenias, and the thought that this will reduce reactive oxygen species and therefore decrease expansion of the clone. And the goal here is to establish clinical trials at Mount Sinai, and we're currently in conversations right now of what group to do this in. So in conclusion, clonal hematopoiesis results from the acquisition of somatic mutations in hematopoietic and progenitor cells. It results from aging and environmental insults. Clonal hematopoiesis increases your risk of myeloid malignancies and cardiovascular disease. CCUS, which is clonal hematopoiesis plus a cytopenia, leads to a higher risk of leukemia than CH alone. And the P53 pathway plays a role in clonal hematopoiesis and the progression of leukemia. PPM1D is a negative regulator of P53, and targeting the P53 pathway is one potential mechanism for preventing leukemic progression. PROTAC degraders are a new therapeutic class of compounds under investigation, And the Clonal Hematopoiesis Clinic is open at Mount Sinai and taking referrals. And if anyone is potentially interested in this area or research pursuits or any way I can help, even just in figuring out how to navigate Sinai and the training system, I am here. So thank you so much. That's it. Any questions?
Thank you so much. Such interesting work. We'll turn over to the floor for questions, either by unmuting yourself or by entering it into the chat. Maybe you can remind us, I think you said this a little bit at the beginning, but if people want to refer to you, it's not just people with existing hem-onc doctors and solid tumors, right, but you can take referrals from primary care or the inpatient center or whatever?
Absolutely. Usually what we do is if their primary care has really just checked for iron deficiency and that is, they're not iron deficient, they can really come to me at that point and I can do the rest of the workup. So I'm happy to take them. And generally then if I find something else that one, it's either not related to clonal hematopoiesis and then, can be followed by either myself or another general hematologist, or if there is concern that there's actually been progression to more of an MDS state, then we refer to, a malignant hematologist who will take care of the MDS at that Mount Sinai Central.
Question. I'm sorry, I can't unvideo myself. All right, maybe I can unvideo myself. Sorry about that. No, it won't let me. One quick question, PMD-M1, do you see that with diabetics, much more increase in diabetics, insulin resistance?
Yes. So there isn't data on that. It would be great to actually see whether that's the case because, this association generally of diabetes and increased risks of some cancers of what's driving that is obviously, very interesting area. And even the current data that's out there about clonal hematopoiesis being more prevalent in the diabetic population, it's not really understood why. It's thought to be some difference potentially between, with insulin sensitivity or high levels of glucose, but not really understood well.
I guess also for obesity, PMD-M1, PMD1. Obesity as well as anyone look at brown fat?
Yeah, no one has done that as of yet, to my knowledge, but that would be a really interesting area.
Yeah, there is one question in the chat from Dr. Radin. When a CHIP patient is identified, how often do you repeat the genetic panel to look for acquisition of additional mutations? Should the bone marrow be banked prior to progression to AML?
Yeah, so generally so this is a really developing field. So there's no guidelines yet. And probably within, I would say the next several years, there will start to be guidelines about monitoring for this because there are CHIP clinics that are being opened sort of across the US. So the thought is to be able to collaborate in making guidelines for this. But generally, we do sequencing every year to see two things. One, if there is the acquisition of other mutations, which would lead you to think that there's progression of to potentially a myeloid disease, and also to see the rate of the expansion of the clone, because it's thought that it may have less to do with actually your starting size of the clone and how fast your clone size expands that puts you at risk for developing myeloid disease. There currently, if you have a cytopenia, which would go along with just workup for MDS, part of the workup is to do a bone marrow. So that would definitely be an indication for doing a baseline bone marrow. But if they only have the mutation, there's currently not recommendations to do a bone marrow, although some providers are now offering it. So people have an idea of what the baseline is. But being we have nothing to do to the bone marrow yet to be able to prevent progression of the disease, people generally don't offer that.
I have a question about like a referral criteria for your service. And in the past, I have learned about like it's a concept called like unexplained anemia in the elderly. I think that kind of population really would really like fits for default to your clinic.
Right.
Am I
Absolutely.
right?
Absolutely. So, and the issue with this is that being that this is a developing field, many times it's thought that elderly who have low counts do not go through a full sort of, depending on their age and their status in general, their health status in general, don't actually get diagnosed with MDS, but probably have MDS, or they have potentially CCUS, which is most likely what this is. So therefore, knowing this, how does it sort of change their treatment? And there will be sort of a lot of back and forth of this over time, because obviously you don't want to put patients through something that they don't need to if it's not going to affect them in their lifetime. But with that said, an understanding of that, so they don't go through a fuller workup, and something more invasive, definitely makes sense for an initial referral, because really all it is a blood draw, and then you sort of have it on record and know potentially what's going on. And this clinic is really an endeavor, one, to be able to screen patients and make sure we're doing what we can, even though that's limited, but really also to better understand this, so we can really start profiling who is high risk, and, then decide who will benefit from clinical intervention.
Great. Thank you so much.
Thank you, Dr. Marcellino, for such an exciting talk. Really great to hear about the work that you're doing. And our PGY3s rotate at the Mount Sinai West Heme Clinic, so this might be a good source of potential referrals, especially for the anemia and the elderly that Hayato mentioned.
Absolutely.
I'm wondering if you could talk about, I know it's very early, and it wasn't clear to me, is the PROTAC therapy being used in humans yet?
Yeah, so they're not this PROTAC that we're developing, but the three PROTACs are: one to the estrogen receptor, one to the androgen receptor. Oh, clinical trial though, not FDA approved for.
Yes.
Estrogen receptor, androgen receptor, and then the newest was a BTK for different hematologic malignancies. This is sort of the first foray into seeing how they work really in humans from a, pharmacokinetic dynamic standpoint, because it's presumed that dosing will be very different than inhibitors are. And so I think the exciting part is really the thought that you can get higher potency with lower doses, and potentially could so some of these are IV, but actually two of them are oral. So the thought also that these could be oral medications that could be taken and last a long time would really be promising, but we'll see.
I guess as just a follow-up to that too, I'm wondering, are there any potential, I know with a lot of these really targeted therapeutics, we have a lot fewer side effects than traditional chemo, but what are the potential risks of like a phosphatase knockout like this? Is it really targeted, or is there potential?
Yeah, so that's what we're trying to figure out, because PPM1D regulates other signaling pathways besides the P53 pathway. So it's involved in the PI3 kinase pathway. It's involved in other portions of the DNA damage response pathway, as well as other apoptotic pathways. So, when I had talked about those pluripotent stem cells where we have the different clones with PPM1D in it, what we're trying to do with that with transcriptomics is understand in the malignant clone what are actually the pathways that are important, that are driving it. And so in cancer patients, what part of PPM1D is really overactive, and what pathways is it really targeting? Because like you say, with all these inhibitors, there's always off-target effects. And so I think that remains to be seen. The question is, though, is it seems, at least with MDM2, there's a differential of expression between malignant and normal hematopoietic stem cells. So the reason that it's believed that these nutlins are working so well is because there's actually that difference in protein expression of the amount. So therefore you can sort of at low doses take care of the malignant cells, but not really hurt your normal stem cells, which is really the problem with traditional chemotherapy, because chemotherapy just knocks out everything. So the question is with PROTACs is if you can get a similar sort of very low dose response that takes care of sort of the surplus amount but that'll remain to be seen. I think one other exciting thing just to say is there's also this thought of developing PROTACs, and a paper, if you look in John Jin's group, they recently published about folate tagged PROTACs. So cancer cells have higher expression of folate receptor in general. So the thought is to be able to specify a cell that you want the PROTAC to go to. And so therefore higher cancer cells with higher levels of folate receptor should be able to take up the PROTAC. So that's very exciting to think about potential specificity to certain cells.
Excellent. All right. Well, we made it to 1 o'clock. Thank you so much.
Yeah. Any other questions, feel free to email. And thank you so much for the opportunity to speak.
Perfect.
Thank you, Dr. Marcellino. All right.
Thank you.